colleagues, welcome to the second annual OncoAlert Colloquium brought to you by the OncoAlert Network and our amazing partners at ESO, the European School of Oncology, eCancer, EONS, the European Oncology Nursing Society, MASC, the Association of Supportive Care, SIOG, the Society for Geriatric Oncology, IGCS, the International Gynecologic Cancer Society, and SWOG Cancer Research Network. My name is Gilbert Morgan. I'm a clinical oncologist, displaced Texan practicing in southern Sweden, and director of the OncoAlert Network. The colloquium, which you're about to see, is an end-of-the-year review taking place daily from January 10 to January 16, bringing you the most impacting findings in oncology of 2021, divided by tumor type, and delivered by an amazing hand-picked faculty of world-renowned oncologists, oncology nurses, and of course, amazing patient advocates. This, as with every OncoAlert initiative, has been realized with absolutely no financial support. All the presentations what you are about to see this week will be free, always available, and will require no registration, and we will not be tracking your data. The amazing faculty that makes up our network believes that through working together and making education available to all is the only way to move forward for the development of our field and for the better treatment of our patients. We welcome you to day 6 of the colloquium, where we'll be seeing presentations on gynecology and the IGCS and ESO sessions. Our presenters are myself, Dr. Gil Morgan from Skåne University Hospital in Lund, Sweden, Dr. Don Dizon, Director of Pelvic Malignancies Program at Lifespan USA, presenting on ovarian cancer. Moving on to the IGCS sessions, Dr. Kathleen Schemeler, Professor of Gynecological Oncology at MD Anderson, presenting on cervical cancer. Dr. Allison Warner, consultant at Memorial Sloan Kettering, presenting on melanoma. Ending with the ESO sessions, Dr. Giancarlo Pruneri, head of the Department of Pathology, Istituto Nazionale, Milan, Italy, presenting on intelligent pathology, and ending with Dr. Pierfrancesco Franco, ESO Advisory Board member, Radiation Oncology at the University of Turin, Italy, and presenting on the role of remote learning. On behalf of the OncoAlert Network, our partners, and our faculty, it is an immense honor to be able to present this colloquium for you, our colleague. So without further ado, a great honor to get us started with day 6 of the OncoAlert Colloquium.
Hi, my name is Don Dizon. I'm at the Legaretta Cancer Center at Brown University and Lifespan Cancer Institute, where I practice medical oncology, specializing in pelvic malignancies. I've been asked to join the OncoAlert Colloquium to give the update from 2021 for ovarian cancer, and I'm just thrilled to do so. So we will be covering 5 reports that came out in 2021. They are listed here. The first is relating to the duration of maintenance bevacizumab in the frontline setting based on AGO OVAR 17. We'll look at the update from the SOLO-1 trial that established olaparib as a treatment for people with a newly diagnosed BRCA mutation-positive ovarian fallopian tube and peritoneal carcinomas. We'll review the Desktop 3 trial, which evaluated the role of surgery for relapsed ovarian cancer. The OREO trial, which addressed the question of whether or not it makes sense to re-challenge patients with olaparib after progressing on prior exposure to a PARP inhibitor. And finally, the top-line results from the Soraya trial looking at mirvetuximab for platinum-resistant disease. To start, let's go through the presentation from AGO OVAR 17, which looked at the treatment duration for bevacizumab when combined with carboplatin and paclitaxel in the frontline setting of treatment in epithelial ovarian fallopian tube and peritoneal carcinomas. This is the study schema. It was open to patients with stage 2B through 4 ovarian cancers of all histologies. Otherwise, pretty standard eligibility criteria. The randomization is 1:1, chemotherapy using standard carboplatin and paclitaxel with bevacizumab starting at the time of chemotherapy and continuing for either 15 versus 30 months, with 30 months being the experimental arm. The primary outcome was progression-free survival. So this is the endpoint of PFS comparing Bev15 to Bev30. As you can see, median PFS was significantly unchanged. So the hazard ratio was 0.99. They did a separate analysis using what's termed restricted means, again, demonstrating essentially similar outcomes with a longer compared to a shorter duration of bevacizumab maintenance therapy. Overall survival is also reported at ASCO 2021, showing again no significant improvement in overall survival with the use of bevacizumab for 30 months, much more obvious using a restricted means analysis. So for people with newly diagnosed ovarian cancer stages 2B through 4, who the decision has been made to use chemotherapy plus bevacizumab, there is no survival advantage to treatment for more than 15 months of therapy. Moving on, we'll talk about the updated analysis of SOLO-1, which again established olaparib as a maintenance therapy following chemotherapy for people with BRCA mutation associated ovarian fallopian tube or peritoneal carcinoma. What was published in the Lancet Oncology was the 5-year follow-up. To remind you, SOLO-1 was presented in 2018 and published as well with the first author of Kathleen Schemeler. It was a randomized double-blind, placebo-controlled study that enrolled almost 400 people with stage 3-4 ovarian cancers, restricted to high-grade serous or endometrioid histologies. Everyone had a BRCA mutation that was confirmed. Everyone received surgery followed by chemotherapy, and the treatment groups were assigned in a 2-to-1 fashion, olaparib versus placebo. When first published in 2018, the hazard ratio was 0.3 favoring olaparib. Indeed, more than 50% had remained progression-free with the use of olaparib, and a significant, clinically significant improvement in 3-year progression-free survival of 60 versus 27%. What was impressive, as published by Banerjee, its first author, is that these results are sustained. Median progression-free survival was reached with olaparib at 56 months versus 14 months with placebo, hazard ratio of 0.3, statistically as well as clinically significant. These data confirm that for people with newly diagnosed BRCA mutation associated ovarian fallopian tube or peritoneal carcinomas, that maintenance olaparib following chemotherapy is indicated and results in a sustained progression-free survival advantage. We are still awaiting further follow-up to evaluate for overall survival. Moving on, we have the publication now of Desktop 3, which was a randomized trial looking at the role of cytoreductive surgery in recurrent ovarian cancer. Desktop 3 follows on 2 prior studies, which developed the AGO score based on performance status, resection status following first or at the time of initial presentation, and the presence or absence of ascites less than 500 mL. That was came out on Desktop 1 and was validated in Desktop 2 with a positive AGO score, meaning all 3 criteria were present: a good performance status, complete resection at the first surgery, and presenting with less than 500 mL ascites, predicted with 95% probability complete resection in more than 2 or 3 patients. And Desktop 2 was then launched to look at those volunteers in first relapse with platinum-sensitive disease and a positive AGO score. The randomization was to cytoreductive surgery or no surgery. Platinum chemotherapy was then strongly recommended following the surgery, and also in those patients who did not undergo surgery. These are the overall and progression-free survival curves favoring the use of cytoreductive surgery. Median OS was 54 versus 46 months with a statistically significant hazard ratio of 0.75, and progression-free survival was also favoring cytoreductive surgery with a median of 18 versus 14 months, a hazard ratio again statistically significant at 0.66. This is the forest plot looking at subgroup analysis, again showing that cytoreductive surgery was overall better than not doing surgery in this very highly selected population. So for people with recurrent ovarian cancer who meet criteria for a positive AGO score, surgery provides that survival advantage. Now, it should be noted that the United States study from GOG showed that cytoreductive surgery was not associated with a survival advantage. I think the biggest difference between this and the US study is the selection for patients with the AGO score, which is predictive of cytoreductive surgery and now is showing association with a survival advantage. Moving on, let's talk about the OREO trial, which was presented at the ESMO Congress. This looked at patients who had a prior course of maintenance PARP inhibitor and had relapsed on that. They were treated with or without surgery and with platinum therapy with no rise in the CA-125, so essentially a serologic response. Also of note, there was no limit to the prior lines of treatment. There were two stratifications, so BRCA mutation associated ovarian cancer cohort, and then another cohort without an association with BRCA mutations. The random assignments are here, olaparib versus placebo, and the primary endpoint, again, was progression-free survival. You see here, in terms of the randomization, it was 2-to-1 stratified by prior bevacizumab therapy and also by prior lines of treatment. I should also note that the eligibility criteria did differ by whether or not a mutation in BRCA was present. Prior PARP exposure was required for greater than or equal to 18 months after first-line chemotherapy, or greater than or equal to 12 months after second line or later. This was much shortened in the absence of a BRCA mutation, prior PARP exposure for at least a year in the first-line maintenance setting, or for at least 6 months in the second-line maintenance setting. These were the main results in the patients who had a known BRCA mutation. There was a statistically significant improvement in progression-free survival of 4 versus 2.8 months, a hazard ratio of 0.57. I should note, however, that there was this exceptionally steep drop-off within the first 3 months, likely corresponding to the first CT scan. So this group of, quote, exceptional responders, one could say, because they responded again to a PARP inhibitor after progressing on one, is a highly selective population, but it looked like there was a very small minority who had an absolute benefit to treatment. This is what was found in the cohort without a BRCA mutation. Median PFS, again, also still doubled from 2.8 using placebo to 5.3 months. Again, you are seeing that very steep drop-off in terms of remaining progression-free within the first 3 months. But you're seeing 30% at 6 months who appear to be doing well compared to 7% who received placebo in this cohort. Again, an interesting and important finding. HRD, homologous recombination deficiency status, did not predict the outcome. And this really does suggest that platinum sensitivity is a biomarker and predicts for response to olaparib, even following the point of progression of maintenance olaparib. It also suggests that maintenance PARP inhibitor does not impact platinum sensitivity. So for people with recurrent ovarian cancer who have progressed despite prior PARP inhibitor treatment, rechallenging with maintenance olaparib is a reasonable option. It is not a curative option, provided they had responded to platinum therapy in the second or later line setting. Finally, I'll just bring up the top-line results, which were released by the company ImmunoGen of their SORAYA trial, looking at the folate receptor alpha antagonist mirvetuximab soravtansine in ovarian cancer. Just to remind folks, SORAYA is a single-arm study of mirvetuximab in people with platinum-resistant ovarian cancer, meaning that they have relapsed within 6 months of prior platinum. Everyone had to have a tumor that expressed high levels of the folate receptor alpha, and they had up to 3 prior regimens, at least one of which included bevacizumab, with a main endpoint of objective response rate. This was not centrally determined, but investigator assessed. So the top-line results, as reported by the company, was an overall response rate of 32%. And this was regardless of prior PARP inhibitor or number of prior lines. The median duration of response was about 6 months. Mirvetuximab was reportedly well tolerated, with the most common treatment-related adverse events being ophthalmologic, blurred vision, keratopathy. Nausea was present in about a third of patients, although not serious, grade 3 to 5 in any. So again, these are top-line results. We do await the presentation of these results so we can more fully vet them. I will also remind you that this was a single-arm study, but again, encouraging given the lack of good options for patients with platinum-resistant ovarian cancer. So the conclusion with SORAYA is that for people with a platinum-resistant ovarian cancer, a targeted treatment may be available for those who have high folate receptor alpha expression on their tumors. However, I'm prefacing this by saying we need to see the full presentation of SORAYA so we can get a better sense of the data itself. So with that, I'll close. It was a very important year for those of us who treat gynecologic cancers. The advances in ovarian cancer continue. These are only 5 of multiple other really important results that not only establish or confirm the role of certain treatments, including the PARP inhibitors in ovarian cancer, but we also learned we have much more work to do when it comes to the role of immunotherapy in ovarian cancer, and really promising novel agents that are coming to the fold for treatment for patients without a marker of PARP inhibitor response, meaning those patients without homologous recombination deficiency, loss of heterozygosity, or a genetic or somatic BRCA mutation. There may be options that will prolong or preserve progression-free survival in the frontline setting. I look forward to what comes out in 2022. And this concludes my presentation. Thank you very much for the invitation, and everyone have a good day.
Hi, thank you so much for joining us for the 2021 OncoAlert Colloquium. My name is Allison Betof Warner. I'm an assistant attending physician on the Melanoma service at Memorial Sloan Kettering Cancer Center. It's my great privilege to share with you the 2021 melanoma updates. So let's just dive right in. So we'll start by talking about some of the long-term follow-up data for modern treatments for metastatic disease. Second, we'll get into some of the long-awaited data on sequencing of therapy between targeted therapy and immunotherapy. Next, we'll talk about some updates on the treatment of stage 2 melanoma with adjuvant therapy. And last, we'll cover some of the new agents that are making a splash in melanoma with promising data for the treatment of metastatic disease. So to start with the long-term follow-up data, we'll start with CheckMate 067. So CheckMate 067, by way of reminder, was a phase 3 randomized trial for frontline treatment of metastatic disease. Patients were randomized 1:1:1 to nivolumab plus ipilimumab versus nivolumab alone versus ipilimumab alone. They were treated until progression or unacceptable toxicity. And the updated data provide minimum follow-up in all patients of 77 months. Shown here are the overall survival curves. You can see the ipilimumab in gray, nivolumab in green, and nivolumab plus ipilimumab in the maroon color. As we've seen in the past, there's nice separation of these curves. What was really exciting and novel this year is that the median overall survival has now been reached in the nivolumab plus ipilimumab arm. So in this combination arm of nivolumab plus ipilimumab, the median overall survival was 72.1 months. If you think about how far we've come in the last decade, to have a median overall survival in the 6-year range is really quite incredible, and really says quite a bit about how far we've come. Also presented were the treatment-free survival data. So if we look at the nivolumab plus ipilimumab arm, 77% of patients were off study treatment and never required subsequent therapy at most recent follow-up. 18% of patients did require subsequent therapy and 5% were still on study therapy, but treatment-free survival, 77%. Next, let's move on to the Columbus data. So Columbus was a phase 3 randomized trial of oncorafenib plus binimetinib versus oncorafenib alone versus vemurafenib in patients with either untreated melanoma or melanoma that had progressed on frontline immunotherapy. There's been great enthusiasm about the use of this combination, particularly given its favorable tolerability profile. But one of the concerns with targeted therapy has been duration of response. So we've really been waiting for long-term survival data, particularly with this combination. If we look at the 5-year overall survival, it is 34.7%, which is in line with what we have seen in the past for dabrafenib and trametinib. And if we look at the hazard ratio of oncorafenib plus binimetinib versus vemurafenib, that's 0.67 overall, favoring the oncorafenib plus binimetinib arm. Next up is Checkmate 204. We saw 3-year follow-up published this year. So Checkmate 204, as a reminder, was the study of nivolumab plus ipilimumab, single arm study in patients with melanoma brain metastases. Cohort A, there were actually 2 cohorts here. Cohort A were asymptomatic patients not requiring steroids, treated then with ipilimumab plus nivolumab, followed by nivolumab maintenance until progression or toxicity. There was a small symptomatic cohort of 18 patients, who either had neurologic symptoms or required steroids at the start of treatment. So if we start with the asymptomatic cohort, we'll look first at progression-free survival. You are looking here at 3 different curves. So intracranial progression-free survival in blue, extracranial progression-free survival in red, and global progression-free survival in green. And if we look at a 36-month landmark, the intracranial progression-free survival in the asymptomatic cohort was 54.1%. The overall survival in that cohort at 36 months was 71.9%. If we look at the symptomatic cohort, we still have a long way to go. So progression-free, 36-month progression-free survival in this group, 18.9%, with a 36-month overall survival of 36.6%. All right, let's move on to sequencing of therapy. So one of the great debates in our field has been whether we should start with targeted therapy or immunotherapy for patients who have metastatic BRAF mutated melanoma. And this year, we got results from 2 different trials that both asked very similar questions. So the first trial was Succumbit. We saw data presented by Paulo Acierto at ESMO this year. The second trial was DreamSeq, presented by Mike Atkins at the most recent ASCO plenary in 2021. So Succumbit trial design, patients with BRAF mutated, untreated melanoma, randomized to one of 3 arms. So arm A was starting with oncorafenib plus binimetinib. At the time of progression, they would cross over to ipilimumab plus nivolumab. Arm B was starting with ipilimumab plus nivolumab, crossing over to targeted therapy at the time of progression. And then arm C was a sandwich approach where patients started with 8 weeks of oncorafenib plus binimetinib. There was a planned switch to ipilimumab plus nivolumab. And then at progression, these patients switch back to oncorafenib plus binimetinib. DreamSeq had a slightly more simple design, but same general principle. BRAF mutated, untreated melanoma, patients were randomized to one of 2 arms, starting with ipilimumab plus nivolumab induction, followed by nivolumab maintenance. At the time of progression, those patients would switch to dabrafenib plus trametinib, versus the inverse in arm 2, patients started with dabrafenib trametinib, and at the time of progression, switched to ipilimumab plus nivolumab. So let's start with Succumbit. So 3 arms here. Arm A, shown in blue, was the targeted therapy followed by immunotherapy arm. Arm B, shown in green, is immunotherapy followed by targeted therapy. And arm C was that sandwich approach with the planned switch from targeted therapy after 8 weeks to immunotherapy, and then at the time of progression, back to targeted therapy. And while there were not significant differences between these groups, certainly we can see a general trend here that the oncorafenib plus binimetinib or targeted therapy first arm appears to not do quite as well. In DreamSeq, there were 2 cohorts. So shown in red here is the targeted therapy arm, patients starting with dabrafenib plus trametinib, at the time of progression crossing over to nivolumab plus ipilimumab. The 2-year overall survival rate for that cohort, 52%, versus the patients who started with immunotherapy and then switched to targeted therapy, shown in black here. Those patients have a 2-year overall survival of 72%. This difference was statistically significant with a p-value less than 0.01. Taken together, these data really argue that upfront treatment or first-line treatment for the majority of patients with metastatic melanoma should begin with immunotherapy rather than targeted therapy. All right. Moving on to adjuvant therapy for stage 2 melanoma. So Keynote 716 was a randomized trial of pembrolizumab versus placebo, patients with stage 2B or 2C melanoma, randomized to 1 year of pembrolizumab versus the placebo arm. We have seen data so far only for the adjuvant therapy. There is a crossover group here that we will later see data from. But Jason Luke presented the adjuvant therapy data at ESMO this year. And what we see here are the progression-free survival curve. So pembrolizumab in teal, placebo in purple. And you see a certainly some separation of these curves, recurrence-free survival curves. There is about a 35% reduction in the risk of disease recurrence or death. The hazard ratio 0.65. And this actually has led to very recent approval of pembrolizumab for the adjuvant treatment of adult and pediatric patients with stage 2B or 2C melanoma. More to come here when we see the final data in publication form, but exciting to have a new potential option for patients with stage 2 disease, given that we know that they have a very high risk of recurrence. Last but not least, I want to get into some of the newest agents that we've seen data for over the last year. So first is relatlimab. There's been a lot of excitement around relatlimab for the past several years, and we've now seen some of the data from Relativity 047 that we'll get into. So just to summarize here, LAG3 and PD1 are immune checkpoints that are often co-expressed on tumor infiltrating lymphocytes. They are both negative checkpoints. Relatlimab is a monoclonal antibody that targets LAG3. And preclinical models suggest that there's synergy between targeting LAG3 and PD1 and blocking both of these pathways to activate immune response. So Relativity 047 is a global randomized double-blind phase 2/3 study that looked at the combination of relatlimab plus nivolumab versus nivolumab alone for first-line treatment of unresectable or metastatic melanoma. Primary endpoint here is progression-free survival. And shown here are the progression-free survival curves. So the relatlimab plus nivolumab arm in blue versus nivolumab alone. You see here a median progression-free survival in the combination arm of 10.1 months versus 4.6 months in the monotherapy arm, with a hazard ratio of 0.75 that is statistically significant. Great enthusiasm about these data, particularly because the toxicity profile of nivolumab plus relatlimab does not appear to be significantly worse than nivolumab alone. We expect that there will be a lot more to come with relatlimab in the coming year, but we'll move on next to lifileucel. So lifileucel is a autologous tumor infiltrating lymphocyte product. So just to give a very brief overview here, patients undergo surgical resection. There is a tumor harvest. Tumor infiltrating lymphocytes are separated from the tumor, expanded ex vivo, cryopreserved, and sent back to the treating physician. Patients undergo non-myeloablative lymphodepletion with cyclophosphamide and fludarabine, then infusion of the TIL product, followed by IL-2. This is done in the inpatient setting. Patients then are discharged and followed up. So the Adjuvant C-144-01 study was a phase 2 multi-center study assessing lifileucel for the treatment of patients with metastatic melanoma. And the cohort to focus on here is cohort 2. These patients were all patients who had progressed on prior PD-1 blockade and had received BRAF plus MEK inhibition if they had a BRAF mutation. And we saw a publication of this cohort this year in JCO with an objective response rate amongst these PD-1 refractory patients of 36% and a disease control rate of 80%. Also impressively, the responses seem to be durable despite the fact that this is really a one-time treatment with the median duration of response not yet reached in responders, with a 95% confidence interval of 11.8 months to not yet reached. So last but not least, we will go over some really exciting overall survival data for Tibotec Fusp. So Tibotec Fusp is a novel agent shown here for the treatment of metastatic uveal melanoma, but it's also being explored in other types of melanoma in some data that we've also seen this year. So just to explain this agent a little bit, so in a normal interaction, the melanoma tumor cell will present antigen via HLA to a T cell receptor and activate a T cell. With Tibotec Fusp, we have presentation of the GP100 antigen via HLA-0201. Tibotec Fusp recognizes that GP100 has a anti-CD3 T cell engager and effector activity, activates the CD3 and resulting in a potent immune response. So we see here a publication in the New England Journal of Medicine showing an overall survival benefit with Tibotec Fusp in metastatic uveal melanoma. So let's look at the curves here. So Tibotec Fusp in orange, control group in blue, really quite impressive overall survival benefit, hazard ratio of 0.51, with a median overall survival of 21.7 in the Tibotec Fusp arm versus 16.0 in the control arm. This agent does have a unique toxicity profile. Typically, first 3 doses are given inpatient due to cytokine release syndrome and associated toxicities. But what you can see here is after those first 3 doses, the risk of particularly grade 3 or higher toxicity or significant toxicity is really much lower. And therefore, these doses from week 4 on tend to be done in the outpatient setting. As I mentioned, more to come about Tibotec Fusp in cutaneous melanoma, but really exciting. This is the first data showing an overall survival benefit for uveal melanoma. Really exciting for patients and truly practice changing. So on that happy note, I will wrap up. Thank you again, and we look forward to sharing our updates in 2022.
Hello, everyone. It's a pleasure for me to get this speech related to intelligent pathology after 2 decades into the new century. My name is Giancarlo Pruneri. I'm a pathologist working at the Department of Pathology of the National Cancer Institute in Milan and also for the University of Milan. So what we have in a pathology lab is an armamentarium of different tools, which are, of course, technology, but also procedures. And what we do every day is trying to connect every technology with every procedures, just in order to get a more comprehensive analysis of the diagnostic profile. And as we will see in the next slides, in order to get a more comprehensive approach for the care of the patient, so not only the diagnosis. Why we are doing that at the moment? Because we know that in oncology, we have to detect, to capture multiple alterations within the tumors, as here is exemplified for non-small cell lung cancer, that is a model, a paradigm for the mutational model in oncology. You see that there are a number of alterations in specific genes, which must be evaluated, even if they are at quite low frequency, in order to get an actionability with personalized treatments. You see in the right panel that as soon as you are able to treat the patient with specific and personalized drugs, the progression-free survival in different papers which have been published in the past is significantly higher and better than what has been reported by using a traditional approach like chemotherapy. So these two figures are pursuing to get a more comprehensive knowledge of the tumor in order to get a clinical, a more meaningful approach for our patient. And this is on the shoulder, in my opinion, of pathology. So in order to do that, we have to apply a relatively new technique that is next generation sequencing. That, of course, is a quite complex technique because it's involving different type of technology along with procedures in our institution, and of course, personnel that must be very skilled. So what we, for example, what we as other groups did in the past is a quite comprehensive evaluation of the cost of the next generation sequencing. And of course, this is a quite busy slide. I wouldn't get through the slide, but let me just underline the fact that what we found is that next generation sequencing is absolutely cost effective, provided that the analysis is complex enough, so many genes analyzed simultaneously, and the workload of the institution is high enough. In these different examples, it's approximately 200 cases per year. So, but next generation sequencing is just one of the pillars of the mutational model for in oncology. The other pillar is the actionability of the alteration that we are able to evaluate by using next generation sequencing. And of course, the actionability of this alteration may be pursued by on-label drugs, but also and especially by using off-label drugs or including patients in clinical trial. So it is very important to set a new model of multidisciplinary team that is the molecular tumor board that we implemented at our institution, as others did in different institutions throughout the world. And what we think is that the molecular tumor board is a tool for the governance of precision oncology. Of course, it must take care of the prescription of tests and treatments with drug, which can be approved by the regulatory agency. But also, it is very important taking into account the fact that molecular tumor board should also provide a collection and storage of molecular, clinical, pathological, and survival data. So the molecular tumor board should set a prospectively annotated database, and also the molecular tumor board could be an infrastructure for implementing sustainable innovation in technology and patient treatment within single institution and within the national cancer, the national health system. So, of course, the molecular tumor board is, by definition, a multidisciplinary team. It is very important to underline the fact that there are a close relationship with the multidisciplinary team. So, in my opinion, the molecular tumor board should not be another infrastructure that would add up to pre-existing infrastructures, but should be working in a close relationship and being very closely intertwined with the multidisciplinary team. So this is what we do in our molecular tumor board. So we have delegates from the multidisciplinary team, for example, lung cancer or breast cancer, and they take care of the presentation of the cases, and they report to the patient the results of the molecular tumor board. Another very important feature of the molecular tumor board is the inclusion of new professionals like the bioinformaticians that nowadays should become a professional figure working within the national health system in order to get the best clinical care for our patients. We mentioned before the database. I personally think that this is very important. The database of the molecular tumor board is probably one of the most important source of big data that could be evaluated, for example, by using artificial intelligence, and maybe also evaluated for assessing the procedure within the institution and across the institution. So basically, just in order to see whether we are good enough in capturing the mutation and in treating specific mutation. You see, for example, in our molecular tumor board, we report clinical and preclinical evidences of altered function together with a protein domain involved, but also in silico prediction. And we also collect follow-up data on targeted therapy response. So if you have a database like that, you can, these are the data from the first year of work of our molecular tumor board. You can see, you can report very well the prevalence of analysis with respect to the different histotypes. And also, of course, this is just for lung pathogenic variants. You can also build your own oncoprint. In this case, every patient is a column, and every gene is a line. And you see that, for example, that you can address that the most mutated genes, as expected, are TP53, RAS, and also STK11, and so on and so forth. And you can also evaluate the SCAT scale of the different analyses. And this is not for research. This is for clinical practice. You can address and you can collect data in your own database. You can share the data with other institutions, and you can see, and you can also, as we will see just in a second, see what happens by using specific panels for specific procedures. This is an example. These are very brand new data which are submitted from our molecular tumor board. You see here your performance in detecting actionability, pathogenicity, and you see here the orange area, the actionability, that is the green area, and the actual actioned genes in your clinical practice. You see, for example, that we are doing a quite good job for microsatellite instability, but we have to implement the recruitment in clinical trials for as regard as the KRAS G12C mutations, which have been included as a actionable alteration, and in Italy is especially actioned within clinical trials. So we have to do a better job in order to include patients in clinical trials in Italy with regard to KRAS mutation, and you can do that just in order to evaluate the data in a prospectively annotated database. What we also saw is that you know very well that there are different possible panels we can use. Basically, there are small panels up to 50 genes and comprehensive genomic profiling panels with more than 300 genes. And this is just a comparison of the actionability within different cancer settings using small panel or large panels. You see that there are no significant difference in getting actionable alteration in the non-small cell lung cancer setting, but the situation is dramatically different in pancreatic tumors and also in gastric tumors. You see that by using a small panel in gastric tumors, you are not able to detect any kind of actionable mutation, and this is of course a problem for the patient and for the molecular tumor board, because you are just wasting your time, and in this case NGS is not cost effective, so the main message of this slide is that in order to get patients, especially in clinical trial, you have to run large panels. In order to run large panels, you have to use, to include in your department, more professionals working with data, for example, bioinformaticians, and this is of course a cost for the system, and this must be programmed very well in order to get all the mutational model for cancer patients affordable for the national health systems. So according to those data, what we decided is to switch from a small panel to larger panel. This is in tumor tissue. And you see how here there are other possible applications of pathology in the next future. One is, of course, the liquid biopsy. For the time being, in our daily practice, we especially evaluate liquid biopsy by using the clinical practice, by using PCR, but we are willing to switch on target NGS panel also in liquid biopsy, because we know that liquid biopsy should be implemented in the next future. We also are willing to get the germline target NGS. This, of course, in blood, but we know very well that the NGS panels nowadays in tissue are very effective also in predict germline alterations of patients, and also, of course, pathologists should be also working on bulk RNA-seq and also maybe single-cell sequencing in the future. So it's not just genomic; we have to work on transcriptomic as well. Why we are doing that? Because as ESMO has recommended quite recently, our research centers must evaluate by comprehensive genomic profiling not only the patients, the setting of tumors for which NGS has been already validated by the, for example, by the ESMO guidelines, which are non-small cell lung cancer, prostate cancer, and cholangiocarcinoma, but also other types of tumor. So as a research center, I think that pathology labs should be working and evaluating NGS also in different settings. Again, this is for underline the fact that we must switch from NGS in tissue to NGS in liquid biopsy as soon as possible. For example, with regard to metastatic tumors, we know that breast cancer patients have just a bone-only lesion in 40% of the cases, and we must, in the future, evaluate the genomic profiling of the metastasis, not biopsying the patient, but just obtaining DNA from the plasma. And we know very well that there is a very good concordance between in the results obtained from the tissue and the plasma within the circulating free DNA. A few words on the digital pathology lab. We know that I think that in the future the pathology lab should be fully digitalized. There are a number of pros in order to doing that. You can obtain your digitalized archive. You would have developed a virtual repository. The data could be integrated with the electronic clinical records. You can have a record for genomic analysis, for example, tumor areas, cellularity. You can obtain virtual inter-department and inter-department second opinion. You can, link the data with patient documentation, and you can also develop telepathology. So it is very important, in my opinion, in the next 3 to 5 years, switching pathology labs from the analogic to the digital system. You can obtain a lot of results. These are just some data, quite old data. New data is being recently developed. You can obtain, artificial intelligence system in order to get diagnosis, to detect metastasis. And also, as we have been talking about the molecular tumor board, We know that for the time being, the annotation of the mutation is very time consuming. You have to do that manually, navigating mutation, somatic and germline mutation catalog. Of course, it is very important to develop a system in order to automate this analysis. And of course, artificial intelligence could be very useful. And digital pathology could be linked, as we saw, to molecular pathology in order to detect gene variance interpretation and to link the interpretation to all the other data in order to integrate omics data. But again, in order to do that, you have to establish very well annotated, prospectively annotated database with genomic and clinical pathological data. You have to establish a digital pathology lab. And as soon as you are ready to do that, then artificial intelligence could be a very good work in order to find out what you are not able to find out just using your own brain. Finally, in order to do that, of course, we have to also to updating the pathologist training, because this is a brand new world. Let me just tell you that in Italy, the four years pathology postgraduate course include training in autopsy, surgical pathology, cytology, immunohistochemical interpretation, grading, histological grading, staging, intraoperative exams. Of course, you can do. You are also doing the research, but this is more or less what is needed in order to get a postgraduate course nowadays. In the future, of course, we should also get a training for molecular labs, molecular tumor board. Our pathologists should have notion of oncology, pharmacology, bioinformatics. This is very important. I think that, you know, all the omics and more science, more math should enter the formation of pathologists in the future, economic as well, because we saw that it's very important in ethics and other things. So in conclusion, and these are my take-home slides, pathology lab should switch from diagnosis to diagnosis and care in the future. This is a revolution, in my opinion. Pathology should not be, you know, in their offices just doing diagnosis. They should, they must take care of patients and in all the process, starting from diagnosis to the full characterization with molecular tools. Pathology labs should lead, in my opinion, the mutational approach, possibly co-lead with other professionals like oncologists or bioinformaticians. And the pathology lab should, you know, always taking care of translating the new procedures into the clinical diagnostic algorithm for patient care. We just mentioned transcriptomic, bulk RNA-seq, single-cell sequencing, the lipid biopsy issue. And I think that it is absolutely urgent to complete the digital revolution for a more evidence-based, quantitative, and reproducible approach in our labs. And of course, we have to develop a new educational model. So there is a lot of work to do, but we can do together. We already did a good job in the last 2 decades, but now all the process should speed up in order to get the best care to our patients. Thank you for your attention, and see you around.
Okay, good evening, and thank you for the kind invitation. It's a pleasure to be here and to be able to join the OncoAlert Colloquium 2021. My name is Pierfrancesco Franco. I'm a radiation oncologist. I work as associate professor of radiation oncology at the University of Eastern Piedmont in Novara, Italy, and I'm also involved in cancer education within the frame of the European School of Oncology. So it's really a pleasure to be here and to talk about the role of remote learning, which I think is kind of an important topic to discuss and a valuable tool to improve education in general in oncology, and particularly it's very timely, this type of learning approach in the COVID-19 pandemic era. So I will briefly share the screen. I hope you can see it. This is the layout of the agenda. So I will briefly touch upon a framework dedicated to education in general and to education in oncology. I will discuss about the role of remote learning, and then I will briefly focus on the initiative of the European School of Oncology in terms of offer of e-learning to the people needing education in oncology. And I will briefly discuss about mentorship, and I will head to conclusion. So a framework for education. So whenever we want to deliver education, and this is true for medical education, but also in other settings, we need a precise and structured framework in order to be able to target specific educational goals. And a very good example of proper framing of the educational goal is derived by the Bloom's taxonomy, which was developed in the mid 50s, and it was revised in the early 2000, highlighting the different domain of, let's say, skill set that a learner should develop in order to achieve final educational goal, meaning knowledge, comprehension, application analysis, synthesis, and evaluation. During the revised version of the early 2000s, the taxonomy was somehow revised in order to highlight actionable points to be developed during the learning process by a learner with specific action and specific abilities that were deemed important to be developed. So a learner needs to be able to remember, so being able to recall facts and basic concepts, being able to define, duplicate, list, and memorize. Then another very important skill set is, of course, understanding, so explaining idea and concept with developing abilities that might lead him to be able to classify, to describe, to discuss, to explain, to identify, to locate, and to recognize. Then there's the application domain, so apply using information in new different settings and in new different situations, providing a skill set that would allow the learner to execute, implement, solve problems, to use specific tool to demonstrate specific theoretical frameworks, to interpret, to operate. Then there's the analytic point, so to analyze, being able to draw a connection among ideas, being able to differentiate, to organize, to relate object, to relate ideas, concept, to compare, to contrast, to distinguish, and to examine. And then there's the evaluation process, where the learner might be able to justify a stand or a decision, being able to appraise, to argue, to defend, to judge, to select, and to support. And then the tip of the pyramid of the educational goal is creation. So to create, being able to produce new and original work, being able to design, let's say, clinical trials or biological study, to assemble, to construct, to conjecture, to develop, to formulate, to investigate, and to author. So we can see that education is a complex mixture, let's say, of skill set and abilities that need to be developed to be able to achieve final educational goals. So complexity for sure is a first point that we need to highlight. And then there's also the let's say the setting where a learner needs to develop his own abilities. So more and more the scenario where a person that is having his own education needs to deal with is not certain. So the system are more and more uncertain, and the decision are at stake. So we are no more in the traditional scenario of applied science, where there's a low system uncertainty and a low importance, let's say, of the decision at stakes, where, let's say, from an empirical point of view, a researcher might observe something, let's say in the nature, in the environment, try to replicate these processes, this phenomena within the lab in order to study and to investigate a physical phenomenon. More and more, the situation is controversial. The systems around us are uncertain and the decisions are at stakes. So whenever the facts are uncertain, the values are in dispute, the stakes are high, and the decision is urgent, we tend to be in what Funtovitz and Ravets define a post-normal science context. So we cannot close ourselves anymore in a lab with like control situation and control inputs, but we need to deal with the outer world, and we need to involve in the decision-making process that normally involves research, science, clinical management of the patient. We need to involve all the stakeholders that are around us. So, for example, the patient itself, the patient advocates, we need to involve the politician, we need to involve other professional figures that might help in us in, let's say, choosing the right decision and operating in the right way to solve an issue, whatever issue it is. So education is complex, and the scenario when we need to provide education is also complex. So we need to somehow provide the abilities to the learner in order to acquire the instruments that would allow him or her to deal with a complex context and a complex scenario. And then if we frame down to oncology and clinical oncology, the discipline itself is complex and articulated because it's made of different skill set that are needed. Clinical oncology needs to deal with high-tech solution to solve some specific clinical problems, have to deal with new drugs and need to be able to manage new drugs. The treatment that we provide to our oncological patients are frequently based on combined modality treatment. So different expertise are needed, and the decision are mostly and most frequently taken in a multidisciplinary context. So a clinical oncologist needs to be able to deal with other specialists in order to offer the patient with the best solution. And the approach that we normally have is holistic, so it's not like constrained to a narrow and specific focus, but we need to deal with and offer patient not only treatment, but also we need to deal with diagnosis, we need to work on lifestyle and prevention, we need to be able to manage properly survivorship, as a high proportion of our cancer patients fortunately survive to the diagnosis. Then we also need to be able to communicate to the patient caregivers, to the patient association, but also we need to have, let's say, a more social profile, being able to interface with the society, with the media, with the stakeholders, and of course we need to try to complement our clinical duties with a research oriented perspective. So education, if we want to provide all this, we of course need to understand that the educational goals are complex, the scenario is complex, but also the specific field tend to be complex. And this is taken into account in like formal education that we provide to oncologists or wannabe oncologists, let's call it this way, and that are no longer only medical expertise. They need to be able to communicate, so they need to be good communicator, good collaborator. This is collaboration is of course a keystone. Need to be a good scholar, good health advocate, good leaders, managing a group, and of course good professionals. And of course, the medical schools and the postgraduate residency programs tend to follow this philosophy and operate in a way that the organization is structured to be able to provide the people receiving an education with those skill sets. So the education needs to be comprehensive and provide different competencies. But this is only probably a part of the education that we may be able to provide, because if we think what is today an oncologist or a medical doctor in general, it's probably a little bit different that what we could encounter, let's say, 20 years ago. Because if we compare what an employee or a professional, or in this case an oncologist, was in the past compared to what is now and what would probably be even more and more in the future, the oncology of the past would be working 9 a.m. to 5 p.m., probably working in a corporate office, in a specific institution, using the company equipment, being mostly focused on inputs, try to achieve professional satisfaction by climbing the so-called corporate ladder, doing a predefined work, relying mostly on email, with an approach which is basically mostly focused on knowledge and relying on corporate learning and teaching, while more and more the profile is a little bit different. And this is this applies basically to workers in general, professional in general, but it applies absolutely also in the medical field. So the oncologists would tend to work anytime, anywhere, using any specific devices, being focused mostly on inputs, trying to be self-sufficient and independent, and creating his or her own ladder, trying to customize the work, trying to share information, try to become a leader, so to be able to manage a group of collaboratives, relying on collaboration technology, focusing on adaptive learning, and relying on a democratized learning and teaching. So the normal academic educational offer that comes from university is might be not sufficient, or it could be somehow complemented by something else. And now we can discuss a little bit about remote learning, because I think remote learning or e-learning is something that could somehow complement the normal and traditional education that we might get from institutions that are that normally tend to offer this type of education. When we recently surveyed radiation oncologists in Europe about the usefulness and the effectiveness of the current educational option, most of the respondents, it was I think more than 500 respondents in Europe, thought that online resources could be or would be very important, the most important resource to obtain education for them. So there was a consistent and a very important focus on the importance of online resources, and citing the obstacles that the professional were facing while trying to learn radiation oncology in Europe. Three of the most mentioned items were lack of time, financial issues, a lack of networking and collaboration. And all these points, the time, the resources, and the networking can somehow be solved, or at least be mitigated by remote learning, or in general learning. So I think this is an option that could somehow democratize the educational process and the learning process for oncology professional. And of course, in recently, the current COVID-19 pandemic has prompted a further shift away from face-to-face learning towards an online technology-based methods of teaching and learning. So the people tend to be more used to those kind of options, and particularly the younger generation, those who are, say, tech savvy, and tend to prefer receiving those concise pieces of information vehiculated by an online tool, and younger generation tend to value more a type of learning which is immersive and is some sort of engaging through electronic learning methods that use interactive online technology that are able to facilitate and to enhance a two-way exchange of information between a user and a provider through an online interface. And good examples of interactive online technology are available for educational purposes. So whenever setting a frame of online education, we need to, I think, consider that to be successful, we need to know that there are some type of interaction inherent to an effective online teaching and online education that might be able to increase the likelihood to succeed in delivering a good education. So there's a close relationship, which is some sort of a triad relationship between a learner, the recipient of the education, the instructor, the person who delivers the education, and the content, which is basically the matter of the education, so what is given and to the learner. And all the three points are connected to each other: the learner, the content, and the instructor, and need to be somehow well organized in order to deliver a meaningful content and a meaningful learning process. And this is also being somehow even more developed later on after Moore that developed the first theory of engagement for online courses, where you have a student factor, so the motivation, the learning style, the degree status, the experience, the age, the personality might affect the level of interaction of the student, of the learner. Then you have the course factor, so the factors related to the content, the structure of the course, the interactive tools, the focus, the level of the focus on the interaction. Then you, of course, you have the instructor factors. So how the instructor is technology savvy, the level of engagement and present that he is able to provide to the learners, the motivation, the age, and the personality type. All these factors somehow lead to a level of class interactivity, but it's also very important, and this is stressed by Lear et al. In 2010, that one of the key factors to deliver successful online education is to create an environment which is interactive and is some sort of provided some sort of sense of community to the learners, and this is a way to engage the learners, and then you have like a positive feedbacks with an increased sense of community, an increased interactivity, and an increased level of education and an increased level of learning. So interactivity and sense of community are strongly correlated to the success of delivering a proper education, and this is very important whenever setting an online educational the learner to instructor engagement is also like a very important aspect to be considered, and the rapport of collaboration between student and his instructor is crucial to be able to create an interactive and cohesive environment. It's very important actually for the instructor to be easily contactable by the students about assignment, course material, and grades. And in order to be more effective, online instruction should also include opportunities for the students to be able to interact with the instructor. And so, and with the students, that we already touched upon this, but it's very important, of course, to be able also for the instructor to be able to be contacted easily, also offline, not only during the online teaching, but also afterwards. And the third level is of course the learner to content engagement, which is the process of intellectually interacted with the content, which of course can change and shape the learner's understanding and perspective. And so the idea is that online students should not merely be given a list of resources, but the instructor, so the teacher should design activities that are able to provide opportunity to examine the task from different perspectives, and then can encourage the student to wisely use relevant information during the educational process and the learning process. So let's briefly describe how the European School of Oncology, ESO, is working on e-learning, and is basically using remote learning to deliver cancer education. So ESO, the European School of Oncology, developed e-learning model, which is called ESO, so the remote learning package provided by the European School of Oncology, which is based on high quality education in oncology, free of charge. And so this is very important. No fees are required to take advantage of the educational offer. This offer is accessible independently from a specific location or time, so it can be reachable anywhere at any time. It's on demand, so there's not a specific time that is required to be connected, or some of the offers are of course online. So of course, if you want to be online, you need to connect at that specific time, but of course they can be also review offline. That this is some sort of on-demand type of package, can be accessed by multiple sources, and it's also sometimes some sessions are also streamed through social media. So this is of course very important to further enhance the reachability, let's call it this way, of the educational offer. So the ESO platform has been developed starting from the 2008, and it's been growing ever since until of course recently. All the sessions are CME accredited, so of course this is very important also to be able for the learner to prove actually that he underwent the learning process. It's very important that the speaker can be reached also after the live session for further discussion and to ask questions. This is of course a way to engage the learner and to increase the interactivity by the instructor to the recipient of the education. Some of the session are formal lectures, but there's also interesting formats that are more interactions, such as the clinical case discussion or the EPAT care discussing specific oncological scenario. The offer can be also used by the user offline, and it's interesting because some pathways can be learning pathways can be personalized. So a learner basically can choose his own content with this on-demand approach, and choosing in between the package that is offered via the whole platform. And ESO in a glimpse has been so far a successful project, because more than 1,000 registered users have been recorded so far, coming from 135 different countries, coming from all the continents. And you can see that all the activities are steeply increasing from the beginning to more recently, and then of course the increase is even more steep in the recent 2 years, and this is of course due to the more frequent use of online resources due to the COVID pandemic, and of course challenges that this situation caused to the normal congresses and delivery of the education through live events. And this was something that I was talking about, the distributed learning. So distributed learning is, of course, normally compared to mass learning, which means that all the materials to be learned is provided within a short period of time, while distributed learning, or also called spaced learning, is defined as opposed to mass learning, and is distributed over a long period of time, so that the learner is able to integrate the various separated parts of the material into a unique entity. And the other characteristic that distributed learning adds is also, of course, that is customizable. So the learner can choose the pathway, can choose the topics that are of more interest for him or for her, and so he can basically personalize and customize the educational offer. Another important aspect to deliver, to give education that the European School of Oncology is working on is mentorship. And mentorship is one of the components to develop an effective strategy for career development, where you can have professional practice model, but you can also offer an organizational culture which is fostering learning through different options. And mentorship is so like a individual relationship with a senior professional that normally is doing the same work as the mentee, but not necessarily. So the shape of a mentorship is, of course, very important, and ESO is working on a mentorship program which is delivered through remote tools. So it's basically an online mentorship program which is dedicated to oncology professional, which tend to provide a specific skill set. For example, how to write a research grant, how to be successfully involved in a translational or clinical research project. So some other activities are dedicated to methodology, so how to analyze research data, how to write and publish an article, how to evaluate and select cancer journal, how to prepare and present oral presentation. This is also important. How to evaluate and assess author input metrics, how to successfully claim for a master or PhD program. So all these specific aspects are discussed and are dealt with within the mentorship program that ESO is offering to younger professionals. So to conclude, I hope I gave you a framework of education. I gave you a framing of remote learning and trying to focus a little bit more on the offers that the European School of Oncology is delivering to oncology professional with remote learning. So my conclusion will be a final slide, suggesting you to please have a look at the website www.eso.net, where you can find all the offer that ESO, the European School of Oncology, and ESO, the online platform for e-learning of the European School of Oncology, are offering you, accessible anytime from everywhere and free of charge. So please have a look at that. So I think this is my last slide. I thank you very much for your attention, and I'd be happy to take your question and eventually join a lively discussion. Thank you very much.
So thanks so much for inviting me to talk about the CONSERVE study. Many of the people on the call have lived through this with me, Georgia and Andre and Marcelo and Mila and Ellen. So we're really excited to finally be done with this study and be able to present the results. I have no disclosures, and we were super excited to publish this last month in the IGCS journal and the International Journal of Gynecological Cancer. And I think this study is very important for Mozambique because they're, as we've started screening more and more women, I think we'll have patients who qualify for conservative surgery. And the reason we did this study is that as you all know, the standard of care for early stage cervical cancer is radical hysterectomy, or if a woman wants fertility, radical trachelectomy. Both these procedures require removal of the perimetrium, which has the nerve fibers that are associated with bladder, bowel, and sexual function. And so as a result, these surgeries can have many surgical complications, as we're all aware of, such as hemorrhage, bladder and ureteral injury, and fistula formation. I think also we need a provider with specialized training in gynecologic oncology, and now we are very fortunate to have the three of you, but in many parts of the world, and even the rest of Mozambique, there isn't a specialized gynecologic oncologist to do these surgeries. At the time, when we started this study more than 10 years ago, less than 1% of patients that met this criteria, and I'll talk about the favorable pathologic characteristics, have perimetrial involvement on radical hysterectomy specimens. So when they did studies, they looked back at cases of radical hysterectomy and looked at the pathologic specimens and saw that very, very few had any involvement of the perimetrium. And so our hypothesis was that maybe we didn't need to do such radical surgery in women who had very low risk early stage cervical cancer. So we did a study to evaluate the safety and feasibility of conservative surgery in this group of women. It was a prospective single arm study, so not a randomized study. It involved many centers that I'll go over. We had a sample size of 100 patients, but 100 evaluable patients. All the pathology was reviewed at MD Anderson. So the slides and the blocks came from all over the world to MD Anderson to be reviewed. And because this was a big change from standard of care, we had the study monitored by the MD Anderson Data and Safety Monitoring Board. So this is an independent group of people at MD Anderson, not associated with the study, who would look at our results every 3 or 6 months and decide whether it was safe to continue the study. So these are the inclusion criteria, and this is really important because when we talk about low risk patients, we need to make sure that they truly are low risk. So it was anyone with stage 1A2 or 1B1 cervical cancer, and that's using the FIGO 2009 staging, because that's when we started the study. The tumor has to be less than or equal to 2 centimeters, and that's by exam and imaging. No lymphovascular space invasion. Squamous cell histology, we included any grade, and adenocarcinoma grade 1 or 2 only. So we excluded grade 3 adenocarcinoma because at the time we were really concerned that they were higher risk. Patients have to have a cone. All patients got a cone, either a leaf or a cold knife cone, and the cone margins, as well as a ECC or endocervical curettage above the cone bed, had to be negative for malignancy. And through the study, you were allowed to do a second cone. So if the first cone had positive margins, you could do a second cone to get negative margins. Everyone had to have a negative imaging test for metastatic disease, and that could be a CT scan, MRI, or PET scan, whatever was available at the institution. And And then as the study went on, we added some more inclusion criteria. And one was that the cone margins and ECC were negative also for high-grade dysplasia for CIN2-3 and adenocarcinoma in situ, and that the patients had to have less than 10 millimeters, less than or equal to 10 millimeters of stromal invasion. And I'll explain when we added those in a minute. So there was no randomization, so the patients got to choose their surgical option based on whether or not they wanted fertility. So again, normally these patients would get a radical hysterectomy or maybe a radical trachelectomy if they wanted fertility. So with this study, if they met the criteria, those who wanted fertility got a cone and ECC, and then if they were eligible, again, they could have one repeat cone. They underwent a subsequent surgery with pelvic lymph node assessment only. So no hysterectomy, no radical trachelectomy, just a cone and lymph nodes. And the lymph nodes could be a full pelvic lymph node dissection, sentinel lymph nodes, or sentinel plus full dissection. And again, that changed based on where the site, what their standard of care was, and then also what training et cetera, the surgeon had. The second group, so group 2 was patients who didn't want fertility. So normally they would get a radical hysterectomy, and instead they got a cone and ECC. If the margins were negative, they met the criteria. They then underwent a second surgery with a simple hysterectomy and pelvic lymph nodes. And then we also included this third group, and these are patients who had undergone what we called an inadvertent simple hysterectomy or a cut-through simple hysterectomy. And so these were patients who they didn't know they had cancer, they had a simple hysterectomy, and then on the pathology, they found that there was cancer. But if the cancer was small, less than 2 centimeters, the margins were negative, they met all the criteria, then they could be in the study. So they had their hysterectomy, usually at an outside institution. They came, we saw they were eligible, so we enrolled them in CONSERVE. They signed a consent, and then they went for a second surgery where we removed their lymph nodes. So these were the 3 groups. We followed patients every 3 months for 2 years, and we did quality of life questionnaires, and those were not reported in this publication. They'll be reported later. All the data was collected in REDCap. This was actually the first study we did where we used REDCap. We had some stopping rules just in case too many people recurred, so that we didn't keep the study going for 100 patients. And so you can see here, we enrolled 100 patients between April 2010 and January 2019. So more than 8 years. Andre put the last patient on in 2019. And we had 14 institutions in 9 countries. So you can see here, they were really from all over the world, but mostly from Latin America. We didn't have any sites in Africa, but now for the next study, now that we have all of you collaborating with us, we can include Mozambique. But most of the patients came from MD Anderson, 36 of the 100. And then René Pareja was one of my co-PIs along with Pedro Ramirez, and in Colombia, they put 14 patients on. And then you can see Peru, Barretos, Brazil at that time, both Marcela and Georgia were at Barretos, Argentina, Andres institution in Sao Paulo, Curitiba, Brazil, Mexico, Bangkok, Australia, Italy. So really we had sites from everywhere in the world. We had to enroll 140 patients to get to 100 evaluable patients, because remember, every time when the patient had a cone, they had to come to the pathology slides had to come to MD Anderson for review. And after review, we had 31 patients who were ineligible. And most of the discrepancies were due to the presence of LVSI. And I'm glad Gustavo was on, but what we found is that it would be read as LVSI negative at the primary site, but then when reviewed at MD Anderson, they would find LVSI. And I asked one of the pathologists, and they said, oh, if you look hard enough and carefully enough, many times you can find LVSI. We also had a few patients where the stage changed, or it was pre-invasive disease, so a discrepancy between the pathologists of how much invasion there was, or also in the histology. So again, even though we only needed 100 patients, we had to enroll 140 to get to the 100. You can see here our results, and this is just a table from the paper, but the mean age was 39. Interestingly, more patients had stage 1B1 disease, 67% than 1A2. 48% had squamous cell carcinoma, and 52% had adenocarcinoma. One thing about the study is that the LAC trial results were not available. The LAC study looked at minimally invasive surgery, which we no longer do for radical hysterectomy, but at the time we were, and actually 96% of our patients had a minimally invasive approach. 83% had laparoscopic and 13 had robotic. And that was just whatever the standard was at the institution. And then most of our patients had a full lymph node dissection. This is, again, the table from the paper, and this shows our results. So in the first column, it's the patients who had the cone, and there were, and then just lymph nodes, and we had 44 in that group. In the second one, it was those who had a simple hysterectomy, and we had 40, and then the inadvertent or cut-through hysterectomy was 16. 5 patients across the groups had positive lymph nodes, so 5 of 100 or 5%, which was higher than we thought. And so I think this really led us to say, even with these very early stage cancers, you can have positive lymph nodes, so we have to continue to do lymphadenectomies. Those 5 patients, when they had positive lymph nodes, they were taken out of further analysis, and they all underwent chemoradiation because of the positive lymph nodes. And then you can see here we had 3 patients that had recurrent disease, 1 in the cone group, 0 in the hysterectomy group, and 2 in the inadvertent hysterectomy group. And again, those patients were taken out of the analysis, and I'll talk about each of those cases. These are the 5 patients who had positive lymph nodes. There was nothing higher risk about them. So just a reminder that even with very early cervical cancer, you can have positive nodes. There was 1 patient of the patients who had a hysterectomy that had residual disease in the hysterectomy specimen. This we were also surprised by, but the patient was probably not the best patient to go on the study. So she had a long history of adenocarcinoma in situ. And as you know, you can have skipped lesions with the AIS. So she had her conization that showed a grade 2 adenocarcinoma with 3 millimeters of invasion and a positive margin. So she was able to undergo repeat cone per the study, and that was completely negative. So then, and an ECC. So then she had a simple hysterectomy and pelvic lymph nodes on the conserved study, and she had a 2 millimeter focus of carcinoma still in the uterus, so a skip lesion above. Her margins were negative, her lymph nodes were negative, so she was taken off the study because of this residual disease, and she underwent surveillance and is without cancer at 5 years. But again, this scared us because if this patient had been someone who wanted fertility and we did just a cone and lymph nodes, we would have left cancer behind. But it only happened in 1 patient. Our follow-up is 33 months. We have 3 patients who had recurrent disease, 1 patient in the cone group, 0 in the hysterectomy group, and then 2 of 16 in the inadvertent simple hysterectomy group. This is just the details, and I can send you all the slides of the first patient who had a recurrence. It was one of our first patients at MD Anderson. And she actually had positive margins for SIN3, and she had more than 10 millimeters of invasion. And so we decided after this, it was very, very early in the study, to change our criteria to make it more strict with depth invasion and negative cone margins. And then our other two patients are patients who recurred after a cut-through hysterectomy or inadvertent hysterectomy. And so again, these patients didn't have a cone done first. They just went right to hysterectomy and then were enrolled and could serve after. But in these two cases, they both had, it was 2 of 16, so 12.5% recurrence rate. So we had to stop the study, and we then excluded this group of patients from conservative surgery. We only had 2 patients who had significant adverse events. We had one patient who died 26 days after surgery, after a laparoscopic lymph node dissection of a presumed pulmonary embolus. So again, a known complication for any surgery. And then one of my patients actually had significant bleeding 12 days after CKC, and she was home outside of Houston, and she went to an outside hospital and had a reoperation where they put some sutures in the cervix to stop the bleeding and gave her a transfusion. We have 14 pregnancies reported among 11 of 40 women who, in the group, obviously, that had the cone and lymph node assessment. 1 or 2 of these are Andre's patients. And of the 14 pregnancies, 13 delivered at term. 1 had a fetal demise at 22 weeks. We didn't follow all the women to see who was trying to get pregnant. We just know of the ones who did get pregnant. So we're super excited about the study. The strengths are that it's the first prospective study of conservative surgery and low risk early stage cervix cancer. We reviewed all the specimens at MD Anderson, so it was very, very carefully done. And we also had very good quality and safety of the study procedures monitored at MD Anderson. And a lot of that was with Mark Munsell's help with REDCap and then having the DSMB. And we're super excited that this trial had multiple sites from countries all over the world, high resource and low resource, which I think is important to show that this surgery is safe and feasible in all settings. Our limitations is how long the study took, almost 9 years. And part of that was it's hard to find these patients because of the strict criteria, but also it was really hard to open the study and keep the study running with all the requirements from all the IRBs, all the translations, all the different bureaucratic issues also of carrying out the study, but so that it's done safely around the world. You know, the other downside of this is that the study requires 2 or more separate surgeries with a cone, maybe a second cone, and then definitive therapy. And so that's a lot for the patients and the surgeons, but it's really important so that if we do conservative surgery, we make sure it's done really safely. A lot of controversy, as you know, over the minimally invasive approach with the LAC trial published by Dr. Ramirez. But the LAC trial didn't really impact us because it was published during our last year of accrual. We finished accrual in 2019 and then had to wait 2 years till 2021 to see the follow-up of the patients before publishing it. But the LAC trial didn't change our approach, and 96% of our patients had undergone an MIS approach. When we look at the group of people that had a cone with complete removal of the tumor because they had negative margins before simple hysterectomy, even though it was done MIS, none recurred. But when we look at the 16 patients who had a hysterectomy that was inadvertent and still had the tumor present, 2 or 12.5% recurred. Both of them had undergone MIS surgery, but we really had to take those patients, stop that arm of the study because of the high recurrence rate. And so our study wasn't designed at all to address the question of MIS in conservative surgery, but in this group, it does appear to be safe. And again, if we look at our 2-year recurrence rate, it's low overall, 3.5% overall. But when we look at the different groups, the group that conservative surgery really seems safe in is when we do a cone first and then do the simple hysterectomy and lymph node assessment. So in conclusion, we think conservative surgery is safe and feasible for early stage cervix cancer, as long as they meet all those criteria. So it's really important to have good pathologists like Cecilina and others looking at the specimens very carefully to make sure they truly meet the criteria. Conservative surgery is not recommended for women who have this inadvertent simple hysterectomy. I mean, they've already had conservative surgery, but the cone wasn't done first, and we see higher recurrence rates in those patients. We're still not quite sure what the right treatment for them is. There are 2 other ongoing studies that will help us answer this question as well. SHAPE is a study that Marie Plant is leading. That's a randomized study comparing simple hysterectomy to radical hysterectomy. They've finished accrual and now they're just waiting for the follow-up. And GOG 278 is another study that's almost identical to ours, and they're also almost finished. So we'll have those results probably in 2023 for both of them. So we have many, many unanswered questions. So there's still lots of research to be done. And then just some final thoughts. We're really hopeful that the results and findings from our study will spare women the early and late morbidity associated with radical hysterectomy. Again, a very small narrow group of patients, but in these patients, we think it's safe to do conservative surgery. And this is especially important in Africa and Latin America and other areas, and even in the US, in the more rural areas where there aren't a lot of specialists, yet a high rate of cervical cancer. And then we're really excited to, this is how I got to know many of our collaborators, but we built a great network around the world to facilitate a pathway for future treatment. And then I'll show you this. This is a picture of my 2 co-PIs in 2010, and again, our group in 2019, actually at the IGCS meeting in Rio, when we finally André had enrolled the last patient, and we were just waiting for the follow-up. And then here's, again, a picture from the IGCS of many of us, including André, and all the collaborating sites that we were super excited to work with.
Thank you all for joining us during this OncoAlert Colloquium on the Best in Oncology 2021. None of this would be possible if it wasn't for you, our colleagues, and the continuous support of our OncoAlert faculty. As previously stated, OncoAlert is nonprofit. We receive no funding, so every single one of the initiatives that you see from us is actually done through the generosity and hard work of our faculty. And this is what they do to keep colleagues up to date. This is just one of the ways that OncoAlert and its members keep their commitment to fighting cancer through social media. So a reminder now that all the Colloquium videos are now available on our YouTube channel. Very easy to share. Just share the links. There is no registration. There is no need to put any information, and they will be available from now on. These will also be available next week through our partners at the European School of Oncology and eCancer on their websites. From all of us at OncoAlert, thank you once again for joining us and encouraging you to share all the videos with all of your colleagues far and wide. Tell them to join us in keeping colleagues up to date and forming one strong oncology community. Because no matter the geography, we are all OncoAlert.